What if everything you thought of health and wellness suddenly changed due to a hidden breathing problem that you were unaware of that affects every system in your body? Improper breathing habits are often overlooked in medicine. I'm Dr. Jenny from the Hobson Institute, and this is the Breathing Lab. Hello, everyone. How are you? Welcome to the next podcast for the Breathing Lab by Dr. Jenny. I am so excited to introduce our guest of honor today, Dr. Tiffany Lamberton. Hello, Dr. Lamberton. Thank you so much for spending the time with us today.
Hi, Dr. Jenny. Thank you so much for having me on. I'm so excited to get a chance to talk to you. This is such an honor, so thank you.
Yes, we have a lot in common. Welcome, everybody. This is the Breathing Lab by Dr. Jenny. This is just a way for us airway professionals to bring to the public and to bring to other professionals the experts in the field and what we're going to learn from each other and what they're doing around TMJ, breathing, airway, myofunctional therapy, all the stuff that at least I do a lot in my practice. So I'm so excited. I'm going to read just a little bit of Dr. Tiffany's bio. So Dr. Tiffany Lamberton resides in Washington State and holds a dual degree in physical therapy and dentistry from Loma Linda University. Her career as a general dentist has spanned in various settings. Still, her passion eventually led her to utilize her physical therapy background and dental knowledge to focus exclusively on TMJ disorders and airway dentistry. Her practice centers on the evaluation of treatment of TMJ disorders, and she welcomes new clients through her website and her TMD collective, which I think we're going to talk about a little bit later. Dr. Tiffany also lectures, in many different conferences, and she's a speaker she's an advocate for spreading knowledge about TMJ, airway, and myofunctional therapy. Tiffany is committed to a lifelong learning and shares her expertise through her bi-monthly podcast, Jaw Talks with Dr. Tiffany, where she hosts engaging discussions with guests on various topics within airway dentistry and TMJ related matters. We actually have our own interview coming up, you and me, and you're going to interview me in Jaw Talks, and I'm so excited about that, December 3rd, that evening. So I'm really excited about that. So thank you so much for spending the time with us. And you're in Washington State right now, right? How's it in Washington? Right now it's
good. Yeah, we've had a beautiful fall, and so any sunny days, we'll take it.
It's like 80 degrees in Chicago right now. Don't know what's happening, but it turned like really quickly back to being cold. But okay, I'm going to just dive right into this because I'm so interested in your background. Could you share with us why you started your career as a PT and how it transitioned to dentistry?
Yeah, that's a great story. And I also want to just give a little shout out to our mutual friend, Dr. Courtney Donko, who's an amazing dentist in the Chicago area. And she was just one of my speakers. I did a Women in Dentistry symposium here the first part of September, and she came out from Chicago and spoke at our event. And she was actually the one that connected us, which was amazing. And I just listened to one of your shows with Dr. Roccabato, or Mariano Roccabato, and he's of course legendary in the PT world. So I was lucky enough to go to physical therapy school before there was even DPT. I actually got an MPT back in the day. That's how old I am. But, I loved physical therapy, and I was able to practice as an orthopedic physical therapist, and dove deep into manipulation. At that time, the North American Institute of Orthopedic Manual Therapy, I was like fully in their track. And then what happened was my husband and I decided to get married. He was in medical school already at Loma Linda, and so we ended up getting married between his first and second year of medical school. And so I found myself back in Loma Linda again. And at that time, I just was feeling a little bit burned down on PT. I left like an amazing job in the Bellevue, Seattle area where we were treating some of the Mariners and, pro athletes and doing all this orthopedic manual therapy to, just kind of struggling a little bit, just trying to find a job that I was passionate about. And so I'm just looking around, and my dad is a dentist, and I was like, I think I'm going to go to dental school. And everyone was
Wow.
like, you're crazy. Like, why? I loved anatomy. I loved neuroanatomy. I loved gross anatomy. Doing that again was just, so passionate about that. But what I found is about your, D2, D3 year of dental school, all of a sudden it's all about the teeth. And you kind of forget that big holistic picture of like, well, it's not just our teeth. It's not even just the mandible. It's the cervical spine, and it's our posture and how we're moving together. And I feel like in dentistry, there just became a real disconnect with that. And even with our TMJ training in dental school, it was like so minimal. It was like 2 days, and nobody wants to treat joints, they just want to treat teeth. And, so I found kind of feeling like we need to do a little bit better, I think, in dental school, where there needs to be kind of more of that collaborative care, the interdisciplinary care. So I'm such a passionate advocate for working together with other PTs, with, other people in our so that was kind of like the transition. And, then kind of coming out of dental school, I found was gravitating towards TMD, and I was just wanting to know more, like, what are people doing? What are they teaching? And I know that you've, done a lot of teaching with dentists, and I just think, like you said, we have a lot in common with our passion for education.
Yes, yes, and you know what, I wanted to make sure I let everybody know that's listening and watching is please put your questions in the chat. We're gonna stop at about 30 after and make sure that we answer your questions. So I forgot to say that in the beginning. I'd love to make sure that everybody gets a chance to ask Dr. Tiffany some interesting questions. Yes, so like I did the whole manual therapy thing too. So you learn how to use your hands, right? You learn how to get in there and like feel joints and feel muscles and feel how things move, which is totally not what dentists do. I do both dentists and PTs, and the dentist, the tactile touch is not as developed in that head and neck muscle joint way that manual therapists have. So the fact that you have that, and then you learn the mechanics of the TMJ, and then you use all your knowledge of what you've learned in dentistry, it's like if I had the time, I would love to do that. And so how many years were you in school?
So I did, so 5 years to get my master's in physical therapy. Then I worked for a period of time, and then I was working as a PT and, doing a few prereqs for dental school. And so during that time, that was when I discovered Pilates. And so I was teaching Pilates and doing PT kind of like on the side as I was going through dental school. And then dental school is 4 years. And, so I was really lucky that I had a little bit of flexibility that I could work during that time.
That's awesome. That's awesome. So how does being both a PT and a dentist enhance how you have incorporated it into your career? Like as in the field of TMD, what has that done for you, having both?
Yeah, I mean, like I said, I'm such a big advocate for interdisciplinary care. And I think especially as we're, as I found, myofunctional therapy and airway dentistry, and, starting to speak with, sleep physicians and ear, nose, and throat physicians, like there needs to be kind of that crossover. And I think as a PT, we're used to that kind of model. You're working with SLPs, and you have a complex, neuro patient. We're used to that kind of collaboration. And I think in dentistry, it tends to be, like you maybe in a solo practice, or it just can tend to be a little bit more isolating. And so, like I said, I think just learning to advocate for our patients for the best kind of care. And what I've seen with TMD is it kind of ends up being this sort of gray area between medicine and dentistry. And it's really the only joint in the face. And
That's right.
dentists don't really know that much about it. And they don't really, now that we're starting to get more modern imaging, I think that is, to me, the really exciting part, especially with our young kiddos, is just how we have the ability now to be able to take something like a cone beam CT and to be able to see the skeleton. Does the skeleton support our treatment plan? And, also MRI, which, as a physical therapist, we weren't necessarily ordering those MRIs, but working together with our orthopedic referrals, a lot of times, you're wanting to know, okay, this, rotator cuff tear, what am I working with? Or, maybe in the cervical spine, is there, what does the soft tissue look like? What does the hard tissue look like? And so I think as PTs, we're kind of used to working together in those teams. And unfortunately, I would say that there's a lot of dentists that don't know, first of all, how to order an MRI just for the TM joint, how to correct for the coronal, and all of those different positions of the condyle. And then we've kind of had it in our heads that like we just need to let that joint degenerate, and then we'll address it when the patient has pain. But what we're finding, the more we start to image, is that even these young kiddos where we assume that their TM joints are normal, they're not. And so I think that I'm such an advocate for, first of all, a comprehensive TMJ exam, which includes all of those things with posture, cervical spine range of motion, how do the shoulders look? How do the hips look? Where the dentists are just like, like, I'm going to stop at like rib 2. I'm going
Right.
to stop looking.
Yeah.
You were talking about facial asymmetry, and in dentistry, that's a huge thing. So if you have one TM joint that has, a significant disc displacement in a growing child, you may start to see that chin go to that short side that has that disc displacement, and so do we fix the teeth then just with, orthodontic therapy or, clear aligners, or do we look at the skeleton? And so to me, I'm so excited about, being able to educate our general and our orthodontists about being able to like read cone beam CT, to read MRI, to read posture, to read muscle palpation, because I do that we need to make sure that the skeleton can support our treatment recommendations. So.
You answered my question. What was the importance of the CBCT, the MRI for diagnosing TMJ airway issues? Like there's patients that they're chronic clenchers, right? Chronic clenchers that can't stop clenching. And I have to kind of convince them to get a CBCT. And then you see that their airway is like a
Right.
coffee shop. And I'm like, this is why you're clenching, this is why, but that wasn't available, that's more recent. So that's something that you order for basically all your patients, or CBCT, MRI, anything else in terms
Yeah,
of.
and I'm careful to say that like not every single patient gets everything, you know what I mean? But I would say in my practice, a lot of times I'm getting patients that have already tried some different things and are still in pain and in dysfunction. And so to me, it's like, why wouldn't you want to know the full anatomy before you decide what your treatment, are you going to just do PT and a brace? Are you going to do some type of orthotic or appliance therapy? Or are you going to consider some surgical options as well? And I think that we've gotten really afraid of discussing surgical options with patients. But, you think about, your knee. I mean, a minimally invasive arthroscopic surgery for a 15-year-old athlete, you wouldn't even think twice about it, right?
Right.
Yet, I had a 15-year-old female who is a gymnast, has sustained a number of, head and neck trauma injuries. Both of her discs are completely displaced, out of place, one more than the other. It's causing significant facial asymmetry. It's causing significant deviation and dysfunction of both her muscles in her jaw, head and neck, her cervical spine. She's having pain, she's having locking. And so my thought is like, really, we're going to just let this 15-year-old just kind of deteriorate for the next 30 years until, she's in my chair then with like a closed lock and can only open, 5 millimeters, and she's terrified, So I loved how you and Mariana Roccabato were saying in the cervical spine, you can see these dysfunctions in the adult patient, and then look at the child pediatric patient and see that patient doesn't have pain necessarily, but you can see the dysfunction in the skeleton and the movement. And so why not intervene at that crucial time, especially to me before growth is complete? For females, we're done basically growing by 15. So, you're not going to get more growth of the mandible and the maxilla at 15. And so, if you have, displaced discs at that point, then you're, on the retrodiscal tissue. And, what do you do at that point? Do you just like let that deteriorate and like let it go, or intervene? And so I think, especially, we're going to talk a little bit more about my own experience with my kiddo, but I think our patients deserve to know, what their anatomy is and what their options are. And so I think patients want options, and they want to know. And when you have that CBCT and maybe that MRI, that's data, right? And, you were talking about the airway dimension, people will say, well, that's just a moment in time. Well, it's a measurement.
And like, for example, children just don't get treated. To me, I see in pain, and I see children with breathing problems. So that like the pain patients that have headaches, they've been having headaches for a long time because people don't really acknowledge their pain, and they think that, they're a little kid, they should be fine. Airway is kind of similar. It's like, at what point do you interject and try to guide that growth and development of that craniofacial, the structure and the airway? That's part of it, is educating people that, people start breathing improperly even from birth. There's children, little baby that snore, that come through my practice that have tongue tie issues, and we work on them and we try to improve their nasal and their expansion of their cranium throughout their body. But there's so many children suffering that, don't get addressed because they're a child. And I wanted to just, if you could share a little bit about your airway, your story about how you got into this field of airway now.
Yeah, sure. So, I had been really diving in deep, into like TMJ, imaging and understanding treatment. And then I did some myofunctional therapy training with the AOMT around like 2015, 2016. And my youngest kiddo at that point was about 5. And I'm looking at him and I'm going, oh, he has a tongue tie. Oh, he has a lip tie. And he's, he's mouth breathing, and, kind of like all of the things like the dark circles and, some of the, behavioral things. And so my brother-in-law is a sleep physician. And so I said, I want to have a lab test. And so, as a parent, just to get that sleep study ordered and, go through the night with, he was having significant events every hour. And it was shocking to me as a dentist, that, just here's the, so at that point, again, I had been going to see, looking at different orthodontic growth and development. Does he need expansion? Does he need a tongue tie release? Do we need to do tonsils and adenoids? And so I guess what sparked some of the enthusiasm I have for educating is like, here I am, a dentist and a physical therapist, and I'm having to fight and really advocate for my own child and to decide, what's the best pathway? Like, who starts the process and who should, kind of quarterback the intervention, and how do we measure that success? And that's why I'm such an advocate for the general dentist really learning about airway and, early intervention, because I think that if we can work together as an interdisciplinary team, as a dentist, if you don't have a myofunctional therapist or a PT or, some of our like brilliant SLPs, working together, I think we have a lot of knowledge, and we can really help our patients early in. So, like I said, my practice is not a pediatric practice, and I don't make it sound like I have like a pediatric experience. I mean, I feel like Courtney Donko is like way better at like the early intervention. So I'm kind of like, like I'm getting the people that are already in pain. But to me, modern imaging, I like to say, is kind of like a crystal ball. Is if we can understand what's going on with the skeleton and the musculoskeletal system and the fascia and the movement dysfunction, if we can intervene earlier, to me, every single patient that I hear their story, it's heartbreaking, just what they've had to go through or how they've been dismissed by some of their healthcare providers, or they've spent thousands and thousands of dollars on, treatments that, they're still in pain and they're still in dysfunction. And so, I would say, both as a mom and I feel like in order to make it better for the collective, we have to make it better for each individual patient, right? So I think
Yeah.
sometimes when we have a systemic problem, we look at TMD, like it's such a huge problem, it's like $4 billion are being spent, how can just like one person make a difference? But to me, it's like, if I can just start at that microscopic level of like, if I can help one patient, or if I can help one young child, maybe not go down that pathway of pain and dysfunction. That's where the path came from. That's where like jaw talk and
I love it. It's so many dentists don't know what PTs do. So many
I
dentists don't know
know.
what we can do for them. And
Yes,
I think that some of them think maybe we are competition, and we're not. We're like team players. The
we're
dentists were
collaborators.
collaborators, exactly. There's so many dentists that refer to us, and the ones that understand, they understand to refer. I think dentists just don't know the process of referral and how it works. Like, if a patient is in pain and you know a TMD trained PT that does airway, of course, that's when there's pain, when you give an appliance, right? Something's not fitting right. Something, the body, the muscles, the joints are not able to sustain what you're trying to do as a dentist. Sometimes they get it and sometimes they don't, but I think it's just a lack of education and a lack of maybe just trying out what it would be like to work with a PT. So I totally get what you're saying, and I love that do you actually do any PT right now, or is that something you refer out to right now?
I would say, so I do have some fabulous PTs here in my area that are just phenomenal, that I have as resources. But I also really try to take a little bit of time with the patient to teach them, once we know their anatomy is, I want them to also try to be able to manage it as well, even if it's, maybe teaching them like how to release their lateral pterygoid, or you and I have talked a lot about just, C1, C2. A lot of times you see that dysfunction in the neck where it's just like they're, one side versus the other, even just teaching them some of the, posture techniques or some of the self-care things. I love that you educate a lot on social media with some of like your tips of like, some of your corrections.
Yes,
I think,
I
all
will.
of that stuff is so important. So I do, try to set my patients up for, some physical therapy based interventions. I usually can tell right away if I can beyond what I'm going to be able to offer for them. I don't have a lot of modalities in my practice. And so, if I want them to have, maybe cold laser therapy or ultrasound or, some of those things, or, I'm super familiar with like TENS and things like that. And I know there's some dentists that use that. I don't have that right now. But I think it's of the picture. So yeah, definitely very collaborative, but also always educating every single one of my patients too.
That's awesome. That's awesome. Does your treatments typically entail? Like, I know you go into air, you go into TMD. I think they kind of, they're the same population, but I was wondering, are you doing expansion of the palate? Like, what other techniques do you use to improve
Yeah,
airway
that's
patency and
a
function?
great question. And I know there's some amazing dentists that are doing that with, like I said, Dr. Donko is a great person for that. I'm not doing a lot of that at this point. Right now, I would say, my practice is, trying to collaborate with my orthodontist in the area as well. And I think it's really important because, you have kind of like the pediatric bucket and then you have the adult bucket. And so what I'm finding with my adult patients is that a lot of times they have been put into a sleep appliance, but no one has ever done that comprehensive imaging to find out whether their TM joints can support that position. And so, unfortunately, I have a number of patients that have, been told like, oh, we just need to fix your airway, but they had severe, degenerative changes of their TM joints. They were put into, a sleep appliance, let's say, that put them into like 60% of their protrusive, fixing their airway issue, but then they ended up with a horrible TMJ problem. So I would say like that's kind of like more of like the scenario of the patients that I'm intervening at. And again, I'm for airway, but I think that we forget that the TM joints aren't necessarily healthy. And so we have to be really cautious. And I think, our informed consent with our patients is really important. And patient selection. I'll say, kind of postmenopausal women just maybe are not necessarily going to tolerate being in an appliance if they've already had a history of TM joints. So dysfunction. So I would say, you know, caution to our airway providers, make sure that you're doing your due diligence with both your comprehensive exam and your modern and your informed consent with your patients. And, I think sometimes with clear retainers as well, people think like, oh, I'll just, fix the bite, and you start scrambling the bite and you didn't diagnose the TM joint condition that they already might have had. All of a sudden it's your fault, right? All of a
No,
sudden they're in a closed lock. So
no, but having the member, like in Chile, for example, in Chile, you as a child going through orthodontia, how Mariano works is basically all children go through a TMD assessment before they put on braces. Because, opening up and closing and doing the whole orthodontia for that 2-year period. If there's a hypermobile patient that has clicking and displaced discs, and they go through that, they're going to end up making it worse and being in pain. And if they're not addressed in the beginning, or if you're a dentist that decides to fabricate any kind of appliance and it hurts them and it creates pain and problems in the head, neck, and jaw, it's like understanding that there's help, and PTs are there to really align the neck, create that stable atlas in the neutral position. People that are putting appliances in patients' mouths have to understand that there is an effect of the neck with the jaw position. And if the neck is slightly off in the upper neck, upper cervical spine, because we're in that forward head, there's no room to go. If people ends up twisting and creating a rotation of C1 or C2, that tends to create a cant. That cant will causing problems on one side. When they hit one side, then the other. Over time, that creates a little fulcrum. That fulcrum will cause a disc displacement to slip even more. So I think it's just learning how to work together and learning how to do a really good assessment of the TMJ and understanding, oh, I'm gonna turn that off. Understanding when to collaborate. I'm going to, let me go ahead and take a look. I was going to ask you, your upper cervical spine, do you do an assessment of the upper cervical spine when you are evaluating TMD patients?
Absolutely. Yes. So both, I'm looking at, of course, posture and muscle. A lot of times you'll see one SCM that is firing more than the other. So I'm assessing, posture. I'm assessing, facial asymmetries as well as their bite. And as they're going through those jaw movements, how are the mastication and the muscles of the head and neck? How are they using those? Of course, looking at airway dimensions of looking at, tongue level, Malin-Potty. I know Dr. Zaghi has some different assessments of like, tongue position and looking at tongue mobility. And then also, I think it's important to look at C1, C2, and I think, and the whole cervical spine as well as hyoid position. So then, muscle palpation. So I go through a complete muscle palpation of, is one masseter, more hypertrophied than the other. I look at, temporalis, I look at the muscles of the head and neck. Um, my history, I feel like, is really important too. Do they have connective tissue disorders like Ehlers-Danlos? Do they have a history of like rheumatoid arthritis? Do they have scoliosis? So some of those big pictures. I think a trauma assessment is really important too. Asking the parent, especially if it's a younger child, have they ever fallen on the chin? Have they, been in the car accident? And you start asking these specific questions, and then, let the parent will be like, oh no, they've never had any trauma. And you're like, well, what about this like little scar on your chin? Oh yeah, they fell in the bathtub and there was blood everywhere and they had to go get stitches. And, so not that it's just like one thing, but I think that often, and I know that as a PT, is that when you have, either, injury to the head and neck, whether it's compressive or, a stretch injury, I think all of those things matter to the soft tissue. And we just assume, like you said, that's normal. And it's often not normal.
Absolutely. No, I agree with all of that. I think we just, physical therapists, look at the body as a whole, right? And like how the body, how the rib cage works with the body and the pelvis and how it connects, but how the head connects to the spine, all of that, the way our neck and our mandible connect to the rest of the body. And our posture is, I always tell people, I'm like, if you didn't fall and hurt your jaw, it's probably your posture and maybe an air problem causing clenching and causing tension. So that the have around dentistry and full body, I think that's just a very holistic way to look at a human as a dentist. So I'm so pleased that you exist. I think you're a rock star. I think you're awesome. It's just
Oh, thank
so
you. I
cool.
think you're a rock star. That's so kind.
Okay, I have a couple questions here. This is from Allie Moore. Hi, Allie. Thank you for asking this. Can you both share your clinical experience with prolotherapy for TMD or disc displacement? What results are you seeing?
So I'm familiar with that as a modality, and I think on AOMT they just did a coffee clutch where they had, I don't know if you were on just a week or two ago, they had a PM&R physician who does a lot of that, where she talks about that. I have had I personally don't do it. And I think that we have to be cautious with kind of entering the joint cavity, especially if we don't have imaging. The concern is, first of all, we want to make sure that we've ruled out any type of malignancy, right? If you're going to injecting into the joint, you want to make sure that you've kind of done your due diligence with that. So I know that there are some practitioners that are utilizing it. I'm not going to say like, oh, it's bad. It's not something I utilize. I know a bit about it. But I would say again, first let's look at the picture. Let's make sure we understand the anatomy, and then make sure the patient has their options. And I tell people everything is a risk benefit, right? So, people ask me all the time, should I do Botox in my masseter? Are there risk benefits with it? Yes. Like, does it help everybody? No. Like, is it a tool in the toolbox? Maybe, so I think it's kind of important to have that discussion with the patient of, well, first of all, what are we trying to do? Are we trying to tighten up like the collateral ligaments that are, holding the articular disc in place? First of all, do we even have a normal condylar disc relationship? Or is it, completely dislocated anterior laterally, anterior medially? What is the anatomy to begin with? And what's that? And one of the things is, really bringing in like MRI directed therapy. So I think that the MRI of the TM joint can be really important for some of these patients, because the proton density is going to show us the disc, but also there's a stir image that's going to amplify fluid. So we can look at, is there swelling in the joint space? Is there joint edema, or is there marrow edema? Is there actually, effusion in the bone where the bone is actually breaking down? And so unfortunately, what I see with any kind of treatment is just not on the anatomy of what you're dealing with in that particular patient. And so, same thing with appliances. I think, a lot of people will say like, oh, just like posture them forward. Well, can the joints support that posture position? Or do you have a dislocated disc and then you're loading it more and then you're causing, the bone to break down very rapidly. So, unfortunately, I've seen patients who, weren't diagnosed correctly. They were put into a type of appliance and then had, rapid condylar breakdown within 9 months. So that's where, I don't want to throw our PTs and our myos under the bus, but like that's where we all have to work together, because you're not going to be ordering those, MRIs. I'm going to be ordering that, and we're going to discussing it and sharing it together, and then planning that treatment too. So that's why I really feel like the general dentist needs to be kind of the quarterback, or maybe the orthodontist. But the orthodontists are seeing like so many patients a day. I don't know that they're taking the time to really go through as comprehensive of a view, as sometimes like I try to take 60 minutes with my new, so it's a lot. I think it's important, but you can't see 100 patients a day and do that type of comprehensive diagnosis. So
Yeah, no,
unfortunately, we're, like we call it like same day smiles, where like the orthodontist is just like, okay, well, do you want to start braces today? I'm like,
right. Boom.
oh,
Let's go. And Allie, I would like to say, I definitely, I know about prolotherapy. I've never really found someone in the Chicagoland area that does it, that I've collaborated with, but I did have a podcast with Dr. Tasha Turzo who went over that. So if you want to rewatch that, that should be on my Hobson Institute YouTube podcast playlist. You can watch that. She kind of how she injects and where she goes, and that it's very effective for pain and stability. The Botox, I always wanted to mention, like I always get, should I do Botox? And I'm like, that's not where I would start. Okay. Like, 'cause I have a lot of patients that come in with history of Botox, and I'm like, let's start with alignment. Let's start with getting the joint to roll and glide and the mechanics down so that you are more comfortable. And let's support your throat. Let's do some posterior tongue to soft palate training. Let's calm down your masseter muscles by supporting your throat and stabilizing it. So those are the things that people just don't really know. Sometimes I think dentists go to, it's been
what's
helpful
easiest,
for
right?
them. It's tough because, you want to help your patient, but I've started getting referrals from dermatologists that are doing injections for Botox. And this one dermatologist has sent me like 10 patients recently saying, this is not what I would do. I would go see this PT that knows how to stabilize and reduce clenching, like, so it's learning what out there. Botox, I think there's a place for it, but it's not the place I would start. So anyway, you mentioned Botox. Listen,
Yeah.
I don't see any more questions. I just want to make sure if anybody has any questions. I don't see any more. I am really excited to be interviewed by you in December 3rd. I'm really excited about that. Your Jaw Talks podcast, so that's going to be exciting. I also will be interviewing this really great pediatric orthodontist that does airway work, Dr. Catherine Murphy, and that's on the 17th of December. So that's my next couple of podcasts. But Dr. Tiffany, thank you so much for sharing this time with us, spending time with us, having us understand what the world is like as a PT and a dentist. I'm just so impressed and so enamored by the fact that you went through all that and like the knowledge that you have. I love it. So thank you.
Always a student, like stay humble, stay curious, right? I'm a lifelong learner.
Yes, I love it. Thank you. And I hope to have you on again at some point in the future and hear more about what you're doing. You're doing some great things. And I know you're doing a lot of collaborative things with women in dentistry and this world of TMD and airway. So I'm really excited about that too. So thank you so much. And thank you everybody for listening. You're going to receive a recording in the next couple of days. I thank you again, Dr. Tiffany.
Thank you, Dr. Jenny. Thank you for having me.
Thank you for listening to the Breathing Lab with Dr. Jenny.